All right, good afternoon. I have to apologize, I'm not a surgeon, I'm an interventional radiologist, so I'm just doing procedure using imaging guidance. But, I would like to thank you for the invitation. It's not so often we are invited in this kind of conferences, so I would like to thank you. I'm going to present you a work I started almost 10 years ago on cryoablation of abdominal wall endometriosis. And as you can hear and you can see, this work started in France. So as I mentioned 10 years ago in Bordeaux, in the southwest of France. Then after I developed this at the Sorbonne in Paris before moving to MSKCC and Cornell 3 years ago. So these are my disclosures, not working. Yeah, here we go. I would like to start with just a basic case. So just go back to what we are all doing, it's medicine. So I would like to present you this first case of cryoablation. I would say maybe, I mean, at least in France or maybe in the world. It was in December 2011. This 34-year-old woman came to see my colleague from gynecology surgeon. She came because she had a baby of 6 months ago, and she had a C-section, and she had very severe abdominal pain, 9 to 10. We can feel a nodule increasing volume, but the issue for her is above and beyond the pain. She was a professional triathlete, so she cannot train, she cannot make a living. And that was a serious issue for her. So all the imaging was performed, and on the ultrasound and MRI, they discovered 20 millimeters mass, heterogeneous, and the radiologist at that time mentioned it may be a desmoid tumor. Obviously, I'm not going to explain what it was, but it was an abdominal wall endometriosis because of all the history and the location and the aspect on imaging. So the surgeon, and I'm sorry, maybe it's not accurate, offered the patient to perform a surgery, but this lady was a triathlete, and she didn't want to have any interruption in her practice, and she wanted to go back to her training as soon as possible. So the surgeon came to me, and we were discussing this in DMT about any percutaneous option. Can you do something? And the reason why he came to me is because I was at that time doing some cryoablation for soft tissue tumors located almost everywhere, and sometimes in the abdominal wall, and mainly on desmoid tumors. So I started in 2010, and also I was doing some low flow vascular malformation. Same year, and you can see in this case, first case published was on the breast. And we had some good results. So I told him, hey, why not trying what we are currently doing, this cryoablation of soft tissue tumor, and let's see how it works. But why using cryoablation? Because cryoablation is you're introducing a very small tiny needle between a 17 gauge to 13 gauge, which means 1.5 millimeters to 2.4 millimeters diameter. And at the tip of the needle, using argon gas circulating inside the needle without delivering anything in the tissue, or using nitrogen, liquid nitrogen, we are delivering very cold temperature. And this very cold temperature are producing some cell death when the temperature is reaching minus 40 degrees Celsius. Below this, the cells are killed. Or if we are doing cycle, we can have some osmotic effect. We can have some apoptosis, some immune response, or vascular effect because of the ischemia. And it starts between 0 to minus 20. The good thing is all these effects are helping us to kill the cells. So to deliver this, we have some tank, we have some machine. You can see here, it's quite small. And we are using imaging guidance to place the needle you see on the lower left. We have tank bringing the argon gas we are using in the needle, and we can adjust the length of the needle when the patient, in the mass of the patient. And that's more or less the technique we are using in the abdominal wall. So you have the mass, you see in yellow on the upper left. Then we are sticking a needle, as I mentioned, between 1 to 2 millimeters diameter. We are starting to produce the ice ball that we can see with imaging. We can see it with ultrasound. We can see it with CAT scan or MRI. So we have very good monitoring of what we are doing. And this is very important to stick the needle under imaging guidance to start the process of cryoablation, and then to cover all the mass with the ice ball to allow us to treat the patient, but in the meantime to not having complication. And the complication could be on the skin, or it could be in depth, close to the bowel in case of the abdominal wall. And all of this make this procedure very straightforward. And this is a case, this is another case. This is not my lady I mentioned in the beginning, but this was a location of endometriosis of the umbilicus, where we treated with 3 cryoprobes. You can see on the lower axis to the umbilicus. Before starting, we were doing all what you can see on the right side, which is, so in the gloves there is some warm saline, trying to avoid complication of the skin. We also inject some local anesthesia, so lidocaine between the mass and the skin, firstly to have some analgesic effect, but also to protect the skin by increasing the distance between the mass and potentially the ice ball and the skin. And in depth, in the abdomen, we are doing exactly what you are doing. We are delivering CO2 to do a carbodissection and to have the bowel removed from the area. And this is what we get when we are doing this kind of procedure. On the left side, you have the ice ball. So this is all the black mark you see with a star. It's under ultrasound guidance, so we can clearly see what we are doing. What we are trying to do is to start the ice ball within the center of the mass, and when the ice ball extends outside the boundaries of the mass, then we stop. And on the right side, you see what we obtained with CAT scan, where you can see the ice ball with a triangle and the 2 needles on the abdominal wall. And below this, you see all the CO2 trying to avoid to have the bowel going close to the ice ball. That may produce issues. So that's the technique we used in this patient, and after we developed. So what are the evidence in 2024 now? So like more than 10 years after we started. So the first report I published was in 2014 from Bordeaux. So Bordeaux is the southwest of France. And we published these 2 papers in 2014-2017, where we can see what we did, exactly what I described previously. On the MRI, you see the nodule on the left side, on the upper in the middle, it's under ultrasound, the ice ball in the lower middle, and after 6 months, this one was after 1 year, you see everything is gone. So without doing a surgery in the scar, the patient had this mass result. So the evidence is also compared to currently the publication on management of abdominal endometriosis. In blue is the surgery in light blue, and in the dark blue is the cryoablation starting in 2014. And you see, even if the surgery increased, which is probably because we are treating more and more patients, because we are able to detect these the masses, cryoablation increased with several publications. And this is a summary of the publication. I'm not going to describe them, but I'm going to describe you 2 papers we published. So the first one was published, it's from Paris, from Sorbonne. It's 6 years study, including a clinical trial we conduct. What we demonstrate in this series of 42 patients, we had a very nice pain relief after, with, you can see on the left side, the pain range between 7 to 10, and after the procedure it was almost 0. And it was a quite sustained results, because over 12 months we have like 80% good results after the cryoablation with only very few adverse events. Most importantly, in these patients, we perform a score where we were evaluating how the quality of life and how everything was going after, and we have a very low score. I mentioned, I don't mention, but this study was performed with the team of gynecologists from Hôpital Tenon, and maybe you know there is a famous gynecologist, Émile Daray, in this place. So we have this very promising results. And recently, so like 1 month ago, we published this 10-year follow-up. It's a long study from Bordeaux, more or less the same number of patients, and the same results in terms of pain control with almost 80%. And this study was performed with a gynecologist team. So you may be familiar with Jean-Luc Brun and Horace Roman. We were doing this, and we obtained the same results as the previous study I performed in Paris. In terms of adverse events, we have some issue on the skin, but very low. We had only 3 cases where the ice went to the skin. The reason was because the needle was not insulated at that time, so we had this issue for a couple of patients. We had some paresthesia, but it's maybe also related to the C-section, and we were not able to address this. We had 1 case of bowel inflammation after. The reason is because the CO2 was removed before the ice ball, so the bowel went close to the ice ball and produced this inflammation, but the patient didn't have a surgery after. Another case, and very unfortunate, that's a case, it's a case I did refer by Horace Roman to treat this nodule. It's not abdominal wall endometriosis, it's quite deep, and it was just for him to not be able to do the surgery, so he referred this patient to me to do this procedure, but unfortunately the nerve, the cutaneous nerve was very close, and the patient developed paresthesia. The good thing with the cryo is after 1 year, the patient recover. Your patient has to wait 1 year to recover, but this is something the patient are recovering. But a very tricky and challenging location. So what's next? 2 different projects. One is in Bordeaux, so they are doing a combined approach with surgical and cryoablation for adenomyomas. And another one I'm developing at MSKCC is moving to malignant tumors after surgery treatment where there is recurrences and without any other options. And so that's my final slide. And in conclusion, so cryoablation is something working. I don't say it's going to change the practice, but it may help you to focus on the deep endometriosis, and maybe there is room for this treatment. And I would be happy to collaborate with all of you. We need multicentric prospective clinical trials. We need to develop this in the US. Currently, it's really well ongoing project in France and Europe, but in the US, it's almost zero. So we need also your help to develop this with collaboration. It's not IR work. It's a team effort, and we have to work all together to address these issues to the patient. And there is also some need for research to have a better understanding of what's going on, and so that's been also, we need funding. Thank you for your attention.